Welcome to today's presentation on vitamin D and multiple sclerosis, featuring Dr. Ruth Marrie and Julie Kelndorfer. The MS Society of Canada gratefully acknowledges the educational grant received from Novartis to make this education session possible. The MS Society does not approve, endorse, or recommend any specific product or therapy, but provides information to assist individuals in making their own decisions. And with that, please join me in welcoming Dr. Ruth Marrie.
Thank you for the introduction and for the opportunity to talk about vitamin D and multiple sclerosis today. We are aware that many people have questions about this, so I hope that this goes toward answering some of them. So we'll just get started. So what I'm hoping to cover today is a little bit about the origin of where our interest in vitamin D and multiple sclerosis came from, what vitamin D is, what we know about it as a potential risk factor for multiple sclerosis, and what we're learning about it as a potential disease-modifying therapy as well. So this is a map. Some of you have probably seen other versions of this map that shows the distribution of people affected by multiple sclerosis around the world. So it shows what we refer to as the prevalence of multiple sclerosis, which is really the number of people affected per capita, and it's color-coded to show the world regions where the prevalence of MS is higher. And so you'll notice generally that countries like Canada, which is in this sort of wine-colored red, the United States and Scandinavia and the UK are countries that are further north from the equator, and that countries that are closer to the equator have a lower prevalence. And so this variation in the distribution of MS, which sort of approximated a variation according to latitude, led people to begin thinking about what was different about latitude. And in particular, one of the observations was that one of the things that varies with latitude is the degree of ultraviolet radiation or sunlight that people are exposed to. So people began to recognize that areas with lower ultraviolet radiation were the world regions where we saw more people affected by MS per capita. And since sunlight is the major source of vitamin D, that led to people thinking about vitamin D as having a role. The other thing that pointed to vitamin D being important is that there are some world regions where you might expect the prevalence of MS to be higher based on geography, but where sometimes it was observed that the prevalence was actually lower than you might expect. And that seemed to occur in populations that consumed a lot of vitamin D-rich fatty fish. So this further supported the idea that it deserves some additional investigation. So when we are exposed to vitamin D in our diet, we're seeing vitamin D2, which is ergocalciferol generally. By sunlight, we're getting production of vitamin D in the skin, which is a form of vitamin D known as vitamin D3 or cholecalciferol. Neither of those are actually active in the body. There are other enzymes that need to transform the vitamin D, first in the liver, as you see on this diagram, and then in the kidney. And there are two conversion steps that get us to the biologically active form of vitamin D, which is a bit of a mouthful, 1,25-dihydroxycholecalciferol. Practically speaking, when we measure blood levels, most of the time we're actually measuring one step backwards, which is the 25-hydroxycholecalciferol. But we get these steps regardless of how we get our exposure. We end up with a common biologically active form of vitamin D. Once we have vitamin D, the question is, what happens? Well, as it turns out, there is a receptor for vitamin D. So think about this as vitamin D being like a key, and the receptor is the lock, and so vitamin D binds to the vitamin D receptor. Vitamin D receptors are present on most cells in the body, including immune cells, which we consider to be important in multiple sclerosis, as well as in the brain. So recognizing this sort of supported the idea that it was plausible that vitamin D could have an impact in a condition like multiple sclerosis. So there have been a number of studies trying to evaluate these questions about what effects vitamin D might have. There are a number of animal models of multiple sclerosis. One of them is referred to as experimental allergic encephalomyelitis. It's a condition that can be induced, and it's been found that vitamin D is beneficial in animals affected by EAE. We know that it's easier to promote the animal version of multiple sclerosis in vitamin D deficient mice. And then in studies that are basically done in the lab, we know that vitamin D has important effects on the immune system. So T cells are an immune cell that promotes inflammation. There are messengers that cells use to communicate with one another, and some of those messengers or cytokines can promote inflammation, and so we know that vitamin D in a petri dish effectively can reduce some of those messengers, reducing the messages about inflammation. So we have a number of pieces of information, again, that vitamin D might have some important biological effects, but these are in the lab and in animals, and so neither of these really tell us fully what might happen in people. So there have been a number of studies in people that have tried to tackle this question of, given these effects of vitamin D, and given what we've seen about the geographic variation in multiple sclerosis and how that might vary with vitamin D levels, what do we see in people that might tell us whether or not vitamin D is really a risk factor for multiple sclerosis? So some investigators at Harvard used data from the Nurses' Health Study. So there are 2 large studies of female nurses in the United States who have provided health information for many years. This health information includes both information provided by questionnaire as well as agreeing to provide access to their medical records, to get their physicians to confirm their health conditions, providing blood samples, hair samples, and a variety of other things. So these particular researchers looked at how much vitamin D these women reported in their diet. And so this could be vitamin D just related to what they ate or related to supplementation. And then they divided the women into 5 evenly sized groups and looked at the women with the highest level of vitamin D intake on a regular basis as compared to women in the lowest category of vitamin D. They found that women with the highest level of vitamin D intake had about a 30% reduction in the likelihood that in the future they develop multiple sclerosis. So as I said, they were followed over time. They also looked specifically at women who were taking supplemental vitamin D, and they looked at doses of 400 international units a day as compared to women taking no supplementation, and that they found that those who were supplementing had about a 40% reduction in their risk of developing MS. The challenge with this study, although it suggests vitamin D might be relevant, is that people who were taking more vitamin D might have differences in their diet other than vitamin D that might protect against MS. So somebody who's choosing to take supplemental vitamin D might also have a healthier diet in some other important way. So additional studies tried to look at this a little bit further. So when individuals enter the military in the United States, they're required to give blood as part of a health assessment, and then they need to periodically give blood as part of ongoing health assessments while they remain in service. And so blood that is left over after they do those tests goes into a repository, which is referred to as the Department of Defense Serum Repository. And researchers can request access to those samples with appropriate ethics approvals. The nice thing about this sample is that everybody entering the military will not have had multiple sclerosis at the time they entered, but some people will have developed it over the course of time. So this means that researchers could go back and request blood from individuals who did develop MS. In this case, there were 257 people who developed MS over the period from 1992 to 2004. And they could also identify at least 2 other people who had blood samples who were the same age, same sex, had the same racial and ethnic background, and had their blood collected at the same time. And then they could compare the vitamin D levels of the people who had developed MS with the people who had not developed MS. And so where possible, they took at least 2 samples, so they averaged their vitamin D levels. So this is the 25-hydroxy vitamin D level, so it's 1 step before the final biologically active form of vitamin D. They found among whites that individuals who had higher vitamin D levels had a lower risk of developing MS, and the risk of MS decreased as the level of vitamin D increased. Now you might still wonder, because that's a single study and it was only able to look at individuals of white background because there simply weren't enough non-whites in that particular study. So the Harvard researchers then went and looked in an entirely different population. So they actually went to Finland. So in Finland, there is a maternity cohort. So pregnant women in Finland all get blood screening at the 12th week of pregnancy for a variety of infections, and unless they actively refuse, their leftover blood samples get stored, again, for research purposes with approval. So in these studies, the researchers looked at the question of vitamin D in a couple of different ways. So first, they found that women with MS who had deficient vitamin D levels, so this would be a vitamin D level they classified as less than 50 nanomoles per liter, had a 43% increased risk of developing MS at some point in the future. How did they know that? Because they were able to link the blood samples from this group of women to their health records in Finland. They also looked at what the effects were of the mother's vitamin D level on their children. So they found that if the women had vitamin D deficiency, so again that level less than 50 nanomoles per liter, in their early pregnancy, that their children had twice the risk of developing multiple sclerosis at some point in their lifetimes. They then looked at infants who were born, and they looked at their vitamin D levels at birth, and they found that the neonates who had higher vitamin D levels themselves had a lower risk of developing MS in the future. So if the baby had a blood level of more than 50 nanomoles per liter, they were considered to have a sufficient vitamin D level, and they had a 35% lower risk of developing MS as compared to the babies who were considered to be deficient. There was still some benefit, even if they didn't have a sufficient level. If they were just 1 level up in sort of the insufficient range with a blood level between 30 and 50, they had a 28% reduced risk. So this collection of studies continued to support the idea that lower vitamin D levels, even at the very earliest point in life, increase your risk of multiple sclerosis. However, there are still things we can't control and rule out, and we don't know what those vitamin D levels were over the entire lifetime, and whether there were, again, other differences about individuals who were born with lower vitamin D levels than those who weren't. So in an ideal world, we would be able to do a clinical trial where at the time of birth we randomized you as if we would in a study testing a new medication to getting vitamin D supplementation, so you had a sufficient level for your entire lifetime, and we were able to compare you to somebody who had a deficient level for your whole lifetime. And by randomly assigning you to your vitamin D level, we'd be able to control for all of those factors that we can't measure. But that's a practically very difficult kind of study to do, so we can step back to another kind of new study design, which we refer to as Mendelian Randomization. It takes advantage of the fact that when we're born, our parents are contributing DNA, and each parent is contributing half of our DNA to us. And so their genes effectively get randomly assigned to us. So we didn't get to make the choice. So if we can show that the genes that are associated in the metabolism of vitamin D, all of those processing steps that we talked about earlier, and if we can show that those strongly relate to vitamin D levels, we can try and do a pseudo-randomized study. So there are 4 genes in this study that was conducted that predict vitamin D levels. And so investigators looked at what the risk of MS was in relation to having variations in those genes that were associated with having low rather than high vitamin D levels. In this case, the more genes you had that gave you a likelihood of a low vitamin D level, the higher the risk of your MS. So all of those things put together would strongly suggest that vitamin D insufficiency is a risk factor for multiple sclerosis, and that we might be able to think about vitamin D as a means of preventing multiple sclerosis. So the Harvard researchers who did several of these studies, because of their strong interest in the topic, tried to estimate how many cases of multiple sclerosis we might be able to prevent if everybody had an adequate level of vitamin D. So their estimates are really based on white populations, because that's where most of the studies have been done, and they assume a certain level or frequency of vitamin D deficiency in the population. But based on their estimates, they estimated, if you look at this circle, the pie graph over here with the number 40, they estimated that about 40% of MS cases might be preventable if we had adequate vitamin D supplementation. They also, for those of you who are interested, suggested we could prevent some additional cases by having people avoid smoking, and that we could avoid even more cases by helping people avoid being obese, since we know that that's a risk factor for multiple sclerosis as well. So that's sort of where we are in terms of our understanding of vitamin D as a risk factor for multiple sclerosis. But of course, once you have multiple sclerosis, there are a lot of additional questions about vitamin D that can arise. In particular, whether vitamin D has a role to play as a treatment for multiple sclerosis. So before we get into that, I wanted to review this pyramid picture. And I've referenced some of the pieces of this indirectly already, but to just tell you where I'm coming from on this point. So when we're thinking about information to guide our treatment decisions, we have to consider the level of quality and scientific soundness of that information. And so people have put together a pyramid to show the quality of information and how much we can rely on it, or levels of evidence in our scientific terms. So at the bottom of the pyramid are the animal and laboratory studies, like the ones that I talked to you about at the beginning, that give us some idea about the biological plausibility or likelihood of something playing a role in a disease, but because they don't directly involve people, we can't really use them to make decisions about treatment in humans. The next step up are single examples or reports that might give us an idea about pursuing something, but again, aren't really enough information to make clinical decisions. Case control studies and cohort studies, which are the types of observational studies that I've been talking to you about so far, are the kinds of studies we do when a clinical trial is not possible for practical or ethical reasons, and make use of natural experiments that occur, so the natural variation in people in terms of how likely they are to be out in the sun or to eat fish or have vitamin D in their diet, that might allow us to figure out whether there's a relationship that's of interest. But for treatment studies, we're really interested ideally in the randomized controlled trial. These are the studies that allow us to randomly assign treatment, so we control for all the unmeasured factors and hopefully even out things so that the two groups are reasonably alike, and allow us to make decisions about whether treatment is really effective or not. So these are the kinds of studies that have supported the approval of the disease-modifying therapies that are currently available for MS. So with that in mind, we can think about what's the available evidence for vitamin D as a potential disease-modifying treatment. So we start with some of the observational studies, and this is a selection. There are some others, but in the interest of time, I chose a subgroup. So if we look at the horizontal or x-axis in this figure, you will see in panel A that there are some vitamin D levels. So the far side we see less than 50, so that's our insufficient range in terms of nanomoles per liter. On the far left side we see over 100 nanomoles per liter, so this is going to be our sufficient range. And then if we see on the vertical axis, we see this is a monthly relapse rate. A lot of our disease-modifying therapies, of course, one of our big goals is trying to reduce relapse rates. So what you see here is the lower your vitamin D level as we move across the horizontal line, we see the higher the relapse rate. So this raises the question as to whether higher vitamin D levels might be protective against relapses and whether we should therefore supplement to achieve that. So another study group tried to look at this question. So when they looked at the relationship between vitamin D levels and relapse rate, they didn't find any relationship. So an inconsistency there. That means we need to think about this a little bit further. But what about MRI? So as many of you are aware, we use MRI to look for under the surface disease activity. And so in this particular study, you'll see again, they looked at the 25 hydroxy vitamin D levels along the horizontal axis. So as we're moving to the right here, we see the level goes up. On the vertical axis, we see the relative rate of developing new brain lesions, and you can see that that drops as the vitamin D level became higher. So this, despite the lack of relationship with the relapse rate, did suggest that there might be some benefits of higher vitamin D levels. An additional MRI study looked at almost 500 people over 5 years. Collectively, that group of individuals had over 2,000 MRIs in that 5-year period, and they looked at their vitamin D levels, and they found for every 10 nanograms per milliliter higher that their vitamin D level was, they had a 30% reduction in the likelihood of new lesions that picked up gadolinium. So that's the contrast dye that we give on MRIs to look for new evidence of inflammation. So based on those types of findings, there is an interest in moving to that next level up on the evidence pyramid to try and support the question of giving vitamin D as a treatment. So focused on there have been several. Most of them have been relatively small, and the first ones really focused on safety questions. So I've pulled out a couple to provide you with some information about what we learned about those. So one is the SOLAR study. So it looked at supplementation with vitamin D3, which is the form that we get from sunlight exposure. And so they randomly assigned participants in this study to receiving 14,000 international units a day versus placebo. Their goal was to look at the proportion of people in each of the two groups who didn't have any evidence of disease activity. How did they define that? They defined it by no relapses, no changes on neurological exam, and no new lesions on MRI. So unfortunately, they did not find any benefit of that high dose of vitamin D3 on their main outcome of interest, but they did find a reduction in the number of MRI lesions that were new at 48 weeks. And there was a suggestion of a reduction in the relapse rate, although it didn't reach the threshold that we consider to be scientifically significant. The choline study looked at a different dose of vitamin D, so it also looked at vitamin D3, but it looked at 100,000 international units given every 2 weeks. So you notice two things that are different here, both the dose and the frequency of the dosing as compared to placebo in people who were taking interferon beta 1b or beta seron. They did not see a significant effect either, but like the SOLAR study, there was a suggestion that there might be a reduction in relapse rate. So that's left us with some inconsistencies, some suggestion we still need to consider this. So there are several ongoing clinical trials. If you're interested in knowing what clinical trials are going on worldwide, you can go to clinicaltrials.gov and actually look and see what studies are recruiting people. And so there are several, and I pulled out a couple that I thought would be of particular interest. So there's a study going on in Finland. So like the study, one of the studies I just told you about, the choline trial, they're looking at vitamin D3 as an add-on treatment to an existing disease-modifying therapy. Again, in this case, interferon beta-1b. And they're looking at 20,000 international units a week as compared to placebo. And they're checking, one, to make sure the vitamin D level actually came up into an adequate range, and the number of new MRI lesions at 12 months. There's a study in Lebanon that's actually comparing different doses of vitamin D. So a high dose of 50,000 international units per week, which is adjusting the dose based on the vitamin D level that the person achieves in their blood, as compared to 800 international units per week. And they're looking at MRI findings as well as cognitive function. So thinking, memory, how fast you can handle information, because this is a really important aspect of daily function. In France, they have a study called the Delay MS study. And this is looking at the effects of vitamin D3 on delaying diagnosis of MS after a first attack that suggests MS, like optic neuritis or transverse myelitis. They're using a quite high dose of vitamin D at 100,000 international units every 14 days, again against placebo, and they're looking at the time to MS diagnosis because they're trying to figure out a delay. And then in the US, the VITAM study is looking again at vitamin D3 as an add-on treatment to glatiramer acetate. So in this case, it was Copaxone before its generic form was available. And they're looking at 5,000 international units a day as compared to 600 international units a day. And they're interested in the effects on relapses, new MRI lesions, as well as overall size or volume of the brain. Now, you might say, why are we worried about testing the effects to see if it's worthwhile to take high doses of vitamin D for treating MS? You know, if there's a possibility, why not just take lots of vitamin D? Well, there is a potential risk of too much vitamin D. So if your vitamin D level gets too high, your calcium levels can become too high. So people may experience nausea or vomiting or weakness. You can get bone pain or kidney stones. So if you're going to take very high levels, it requires monitoring. In adults, doses up to about 4,000 international units a day are safe and don't require specific monitoring. Health Canada has indicated what it considers to be the recommended daily intakes of vitamin D, as well as the maximum daily intake that's safe and doesn't require monitoring at various ages, as well as during pregnancy. So the maximum daily intakes are in the area of the kinds of things that we have been thinking about for people with multiple sclerosis when we've been discussing that. So what I've told you so far this afternoon is that I think we have a pretty good body of evidence that vitamin D insufficiency is a risk factor for multiple sclerosis. We do not have enough evidence to support vitamin D as a sole therapy for multiple sclerosis. And in terms of clinical trials, we have several ongoing that should help to clarify for us the role of vitamin D as a treatment, as well as the optimal dose.
Thanks very much, Dr. Ruth and Marrie. We're just now going to hear from Julie, and Julie has a little bit of a personal story about vitamin D. And after this segment, we'll be able to take questions. If you have any questions that have come to mind, please do type them into the chat, as we'll be taking the questions through there and then verbalizing them. Julie, you've got the mic.
Thank you. Hello, everyone. Just want to thank you for the opportunity to join the presentation today and speak to my story of MS. Well, my official diagnosis with MS came in September 2004, 15 years ago, when my son was only 1 year old. My first symptoms appeared when I was in high school in the early 90s. I've experienced an array of symptoms from relapses, like hand tremors where I couldn't cut my food or even tie my son's shoes, or stumbled walking due to the lesions in my brainstem affecting my balance and inciting vertigo, which prevented me from attending my son's Halloween parade at school that year. Or when I just end up saying to him or my family and friends, "I'm sorry, I just can't do that or attend a function," as I'm overwhelmed with exhaustion due to fatigue and intense pain from muscle spasms. Before I was diagnosed, I knew of this disease and the multiple challenges it brings. My aunt passed away with secondary progressive MS. At the age of 52, she could no longer move on her own and speak except for the nod of her head. She lived in a long-term care facility with individuals 2 and 3 decades older than her, who played bingos every Saturday afternoon, not her cup of tea. Canada has one of the highest rates of MS in the world, and I'm one of those thousands of Canadians that live with this disease, MS. But this disease doesn't just affect me, it affects my whole family. I'm blessed to have a wonderful network of support in family and friends. For the past 11 years, we've had a team in the MS Walk called Joshua's Friends Team, who's raised over $120,000. This is a picture of our team this past year. However, it is heartbreaking to read, as a mother, when your son writes when asked how MS affects him, and he says, "It makes me scared to know my mom may not walk tomorrow." He had wrote this when he was about 7 or 8 after attending a kids camp and noticed other kids' parents using wheelchairs. I, like other parents, just want my child to be healthy and happy. But since my diagnosis, there's been an ever-present fear that lurks in the back of my mind. Will my son get this disease? The question for me is how I can prevent this. I'll come back to this piece in a moment. I recall when I was first diagnosed, the learning curve was high into this world of MS. A whole new vocabulary was just one of those things thrust upon me that I had to make sense of. What does it all mean? And how was I to figure it all out? One of the best things for my family and I was attending an MS Connect conference, where we heard a speaker talk about vitamin D, the importance of it, and why every Canadian should take supplements. From this point forward, every morning my family started taking vitamin D drops with our breakfast ritual. I'm both honored and privileged to have begun working with the MS Society 13 years ago, and I'm currently the Director of Government and Community Relations. I'm a passionate advocate for Canadians affected by MS, and I'm so excited to share with you the MS Society's new strategic plan. Discover, Innovate, Act. For the MS Society, as leaders within the MS community, we are privileged to be a part of a determined group of change agents who are working tirelessly to create a world free of MS. Needless to say, we know there's an urgency to this work, that for every day that passes, more Canadians receive the news that they have MS. Since 1948, we at the MS Society have been proud to be part of a community of people living with MS, family, friends, volunteers, donors, researchers, clinicians, and many more in funding research, providing support to people affected by MS, advocating for supports and systems that allow people living with MS to live a full and inclusive life. This year, we have unveiled a strategic plan that not only builds upon the work of the entire MS community since 1948, but with great hope brings a new chapter to move forward our mission of connecting and empowering the MS community to create positive change that helps realize our vision of a world free of MS. Through discoveries, innovation, and collective action, we will work together to alleviate the uncertainty that MS causes, help provide accessible options for disease management, and reach out to partners to eliminate physical and social barriers in our communities. Our new strategic plan not only lays out the roadmap in our journey to create a world free of MS, but we hope it also provides inspiration for all in the MS community to connect and collaborate in order to advance treatment and care, enhance well-being, understand and halt disease progression, and prevent MS from happening. For me personally, as a parent living with MS, the Prevent MS piece speaks to me and gives me great hope that there are modifiable risk factors, such as what Dr. Ruth and Marrie was talking about, such as vitamin D, that we as Canadians can take action on. It means everything to me to be able to take action to prevent my family and friends from getting diagnosed with MS. As a parent, I want to ensure my son's path is different than mine. Furthermore, the MS Society has launched evidence-informed recommendations on vitamin D supplementation that can help people affected by MS make informed decisions about their health. To develop these recommendations, the Society convened a panel of scientific and clinical experts, as well as representatives from other national MS societies and people with lived experience, to discuss the available evidence on the link between vitamin D and MS. The MS Society recommendations provide information about the general role of vitamin D in the human body, as well as reference the Health Canada recommendations, including sources of vitamin D. I encourage you to go to the website and read and share these with others. Thank you once again for this opportunity to share my story and the work of the MS Society.
Thank you, Julie, for that story. We're now open for questions, so if anyone has questions, feel free to type them in. We've got a few that have started to come in already, and we'll just start with those. The first one is for Dr. Marrie. What is considered vitamin D-rich fatty fish?
Yeah, so there are a number of fish that are fatty. So salmon is a good source of vitamin D. Herring and sardines. Canned tuna provides a source of fish. Vitamin D. Cod liver oil is also a source of vitamin D. And then there are some other foods that are high in vitamin D. So egg yolks, for example, shrimp, oysters, or other sources of vitamin D.
Okay, great. Thank you. Another question is vitamin D supplementation. Is there a difference between liquid form or tablet form, and is there a recommendation for either?
So liquid and tablet, it's really whatever you can take consistently. There may be slight differences in absorption, but I don't think that's been very well studied. Likewise, people may ask about whether it matters whether you're taking vitamin D3 or vitamin D2. There's some suggestion that the vitamin D3 that you take may bring your vitamin D levels up a bit more effectively than vitamin D2, which I think is why you see the clinical trials focusing more on vitamin D3. But it is possible to bring up your vitamin D levels with either.
All right. Another question here is, should we be taking magnesium with our vitamin D?
Well, historically, what we've actually focused on is making sure you have enough calcium in your diet rather than magnesium when you're taking vitamin D. Really focusing on the importance of vitamin D in terms of bone health, although that's a concept that people are beginning to think a little bit differently about again. But usually our focus is in trying to make sure you get enough calcium, and your calcium needs will change over the course of your lifetime.
All right. Another question here on vitamin D2 versus D3. As they come from different sources, is there a difference to how they work in the body, and is there a preferred type to be taking as a supplement?
Yeah, so I think that's what I was sort of alluding to a little bit earlier. So they're both going to ultimately get converted to the same biologically active form, so they'll have the same effect at the very end of the pathway. The main difference may be, and this is still a point of some discussion, is that if you're taking a vitamin D3 supplement, it may just be more effective in bringing your level up. So you might not need as much vitamin D3 as you would D2 to bring up the level.
Okay, and another question here is, how do the vitamin D levels relate to delaying or treating PPMS, primary progressive MS? Much of the research speaks to RRMS. This individual has PPMS and would like to know how this applies to them.
Yeah, so that's a good question. So you're right that most of the studies really have focused on relapsing remitting MS because the emphasis, as a disease-modifying therapy in those observational studies that showed effects on relapses. So there's been a lot less study of the effects in progressive MS. There, if I recall correctly, was a study out of the Cleveland Clinic looking at the relationship between vitamin D levels and MRI in people with both primary and secondary progressive MS. And in that study, so one of the things we can look at in some of our specialized MRIs, so not the ones you would routinely go for, but for a research MRI, they can look at the thickness and quality of myelin, that insulation that lines the nerves in the brain, and there was some suggestion that the amount of myelin might be better in individuals with progressive MS who had higher vitamin D levels. But I think that there needs to be more work on that question to help us better understand what the effects might be.
All right. Thanks for that answer. The next question here is, should people with MS be concerned about getting a vitamin D test, or is supplementation enough?
So this is a challenging question. In many Canadian provinces now, the provinces limit our ability to get vitamin D testing. So first thing is, as I said, you can take sort of levels of up to 4,000 international units a day safely and not worry you're going to get to a level that's too much without getting monitoring. The challenge is knowing whether or not you're going to be at the correct level. So there are some studies that might give us some information and guidance about that. So there are at least a couple studies that suggest if you supplement most people, unless you're very far above your ideal weight, that 3,000 or 4,000 international units a day will get most people into the range that we're interested in. If you're very far above your ideal weight, that may not work as well because vitamin D is fat soluble, so you might need higher levels. Because of the lack of testing, we have some basic restrictions about things. If you were fortunate enough to be tested in the past and your health hasn't changed and your weight hasn't changed, then it's reasonable for you to continue at the dose that was effective previously.
Okay, and then this question is sort of related to that one. How do I find out the ideal amount of vitamin D3 for someone who's in secondary progressive?
Yeah, so I think we don't know, an exact amount of vitamin D to recommend based on whether you're relapsing or remitting or secondary progressive. At this point, we usually suggest similar levels. People with secondary progressive MS at one time had relapsing remitting MS, and so generally we encourage people to just continue at what they were taking when they had relapsing remitting MS.
Okay. How can someone with MS find out if they have or a family member has the genes that result in lower levels of vitamin D?
So at this point, there isn't really a mechanism to do that. That's sort of a research-only test, although it does get to a more general question of one day, as clinicians, we would really love it if we could personalize care by knowing something about people's genetic backgrounds, whether they had genes that made them more or less likely to suffer complications of therapy or to make other therapies more effective, but it's not something that's available to us now.
All right. Now this question relates to children. For children 9 and over, is there a danger of giving, let's say, 1,000 IU per day?
Well, if you look at the recommendations that Julie put up, I think it will show you what the recommendations are for children in that age. And so that's in the range that was suggested in the recommendations for children that age. But it's always reasonable if you have a concern to talk to your children's healthcare provider as to whether or not they have any concerns about any supplementation that you're choosing to provide. So these are just guidelines. They're something you can take to a family physician or a pediatrician and say, I'd like to do this. Does this seem reasonable? Does my child have any other health conditions or considerations that might make this inappropriate?
All right. Any suggestions for vegetarians and obtaining more vitamin D?
Well, I mean, vitamin D supplementation is something that you can do. I mean, it is practically speaking difficult purely in your diet to get adequate vitamin D levels anyway, although you can improve it. But really, you can go to your pharmacy, and get vitamin D supplementation, as we've already heard, either as drops or in capsules, and add that to your diet. Because it is fat soluble, it's best taken with your biggest meal of the day, which has the most fat in it.
Okay, this person has had MS for 30 years, and from the question, it appears as though his children do not have MS. Is it advisable for his children to have their vitamin D blood levels checked?
So I think these individuals likely would have trouble accessing by, getting their blood levels checked. In general, the recommendations that the MS Society produced would suggest we would just encourage people who are the children of family members with MS just to take some vitamin D supplementation within the safe range recommended by Health Canada going forward without specifically getting their levels checked. Because 85% of Canadians or more are vitamin D insufficient, even if they don't have MS and don't have a family member with MS.
All right. Thanks very much for that. If there are any other last questions, we've got a couple of minutes left. Feel free to type them in. Valerie does have a kind of a follow-up question regarding the testing. Some provinces' healthcare systems no longer permit vitamin D testing unless you have a medical condition. If you do want to get tested, is there any recommendation of where to go?
So I agree that most provinces have sort of delisted testing for a variety of reasons, including the recommendations by choosing wisely Canada for just the general population. I don't know in any given province where you could go for testing. There are some naturopaths who are sometimes able to arrange for testing. I think they send out the tests when they do that, but I think that's something you would have to look into locally.
We've got Jessica asking a question here. What does the future look like in terms of expanded access for people with MS to vitamin D testing? Again, back to testing, but any comments on that would be appreciated.
Well, so I think one of the things that the MS Society has been working on as part of its recommendations is sort of the bigger picture of things. So, if the Society is going to encourage people to take vitamin D, and if there are recommendations that include monitoring, what can be done to try and improve access to testing if needed. And so I believe this is on their agenda of things to try and work on from a policy perspective, which is why we, sort of heard about the emphasis in the strategic plan on making policy change.
All right. One more question about dosing. Can I take the 4,000 IUs in one meal, or should it be taken across several meals?
It can be taken all at once.
Okay. And one final question here. Could you repeat when you should take vitamin D? I've always taken it before I fall asleep, but it's just been mentioned that maybe it should be taken with the biggest meal.
So, you can certainly take it before you fall asleep. It just may be better absorbed with your biggest and fattiest meal of the day because it is a fat-soluble vitamin. So that may just help with absorption.
Okay, and I think that's it for the questions at the moment. All right, this will be our final question of the session, which is, what do you recommend about, a few more just rolled in here and I lost my position. And you mentioned that sunshine is probably one of the best sources of vitamin D. Is that prevented by sunblock or sunscreen?
Yeah, so sunscreen does pretty effectively block your production of vitamin D. So there's obviously a balance. We don't want people to get skin cancer and early skin aging from sun exposure. But as it turns out, the sunlight is highly effective at producing vitamin D. So you actually need very little exposure during the summer months. This does not apply in Canada during the winter months at all. But during the summer months, having your forearms exposed for 10 minutes is sufficient to make your vitamin D. So if you put on your sunblock, because you're supposed to wait 10 minutes before you go outside, you put it on, immediately go out, you'll get your 10 minutes of exposure, and then you should be able to protect your skin for the rest of the time.
Okay, great. Thank you very much. And thank you everyone for asking your questions. Hopefully you've got quite a few answers there. If you do have any other questions regarding this topic, we will be sending out a short survey, one for the webinar, as well as the ability for you to communicate some additional questions back to us. At this time, we are going to conclude the webinar for today. Thanks to all of the speakers for presenting and for everyone for attending. In conclusion, on behalf of the MS Society of Canada, I would like to wish you all a very enjoyable evening.